Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching video class. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this episode, I am going to discuss 10 more MCQs on biliary atresia, one of the congenital causes for obstructive jaundice. So I do not need to emphasize the importance of MCQs because every qualifying exams like your MBBS, MS, MRCS or DNB surgery or even the medical specialties like MD, DM and all, in every exam, medical exam, you should, undergo this MCQ part of the exam. And especially in competitive medical entrance exams like NEET PG, NEET SS, USMLE, UKMLA, AMC, in all these exams, exclusively they are using only MCQs. So, if you are going to get your PG seat or not depends on how well you are going to answer these MCQs. So, you should know how to, if you want to pass this, competitive medical entrance exam, you must know because they are not going to ask ASCII and all in this exam. Of course, not in MRCS and all, they have ASCII also. But commonly, MCQ is there everywhere. So, you should know how to answer MCQs. So, these series of MCQ videos, which I am preparing and uploading in the YouTube, will give you a systematic way of revising the whole spectrum of general surgery topic by topic. See, in this episode, I am going to discuss 10 MCQs exclusively on biliary atresia. But before going to discuss those 10 MCQs, I want you to watch my video on biliary atresia. Please click this link, go and watch that video first, and then you come back again to this video. Let us discuss the 10 MCQs. Coming to MCQ number 1. A 6 weeks old infant present with persistent jaundice, pale stools, dark urine, and hepatomegaly. The baby was born at term and has been thriving poorly. What is the most likely diagnosis? A. Neonatal hepatitis. B. Biliary atresia. C. Physiological jaundice. D. Breast milk jaundice. The correct answer is of course B. Biliary atresia. Why biliary atresia? Persistent jaundice beyond 2 weeks are not physiological, that too with clay color stool and darker in urine. That suggests obstructive jaundice, and this patient, 6 weeks old infant, so most common is biliary atresia. A is incorrect because neonatal hepatitis may cause jaundice, but usually does not cause acholic stools. Acholic means stool will be pale in color, bile is not entering into the intestine at all. So this is not the case. In case of neonatal hepatitis, you won't have pale color stool. Physiological jaundice also incorrect because all physiological jaundice usually resolve by 2 weeks. Our baby is already 6 weeks old. And breast milk jaundice cause unconjugated hyperbilirubinemia and normal colored stool. Here it is conjugated hyperbilirubinemia. So that is also wrong. Reference is from Nelson Textbook of Pediatrics, 21st edition, chapter 410. Coming to MCQ 2, a 2-month-old infant with suspected biliary atresia undergoes liver function testing. Which finding is most likely? A. Elevated unconjugated bilirubin. B. Low alkaline phosphatase. C. Elevated conjugated bilirubin and GGT. D. Decreased ALT and AST. Of course, the correct answer is C. Elevated conjugated bilirubin along with gamma glutamyl transferase or GGT. Explanation: biliary atresia causes conjugated hyperbilirubinemia with cholestatic pattern, that is high ALP and GGT. Both will be elevated. If only ALP is elevated and GGT is not, probably this may be because of some other cause apart from hepatobiliary, probably a bone pathology, or even pediatric patient also ALP will be normally increased. So A is also incorrect, that is elevated unconjugated. So here obstructive jaundice we have conjugated hyperbilirubinemia, and A is also because of hemolytic anemias or breast milk anemia jaundice. And B is low ALP. No, ALP is always elevated in cholestasis. C is elevated. This is the correct answer. D, decrease ALT and AST. No. ALT and AST will be slightly elevated in this obstructive jaundice. Reference: Sebastian Textbook of Surgery, 21st edition, Pediatric Hepatobiliary Disorders. Coming to MCQ number 3, a 45-day-old baby is diagnosed with biliary atresia. What is the most critical determinant of long-term survival? A. Birth weight. B. Age at surgery. C. Type of feeding. D. Use of steroids. The correct answer is of course B. Age at surgery. Because early Kasai's photoenterostomy before 60 days significantly improves prognosis and bile flow restoration. If you are delaying it beyond this 60 days time, the microbiliary tubules will get fibrous and that will be irreversibly damaged. We cannot, restore the bile flow. That is why the baby must be operated before 60 days if you want a very good prognosis. A. Birth weight is incorrect. It is not a major factor unless the baby is a preterm one. Age at surgery is the correct answer. Type of feeding is not. It is not important and it is not primary also. And the use of steroids are adjunctive and it is controversial. Steroid is not the important, prognostic factor. Reference: Bailey and Love Short Practice of Surgery, 28th edition, chapter 71. Coming to MCQ number 4, a 3-month-old baby has persistent jaundice and acolic stools. Ultrasound shows an absent gallbladder. What is the most appropriate next diagnostic step? Number 1, HIDA scan, that is hepatobiliary immunodiacetic acid scan. B, CT abdomen. C, MRCP. D, upper GI contrast study. Of course, the correct answer is A, HIDA scan. HIDA scan assesses the bile flow into the intestine, that is functional assessment. Non-excretion even after 24 hours denotes baby is having biliary atresia. The B and C, that is CT abdomen and MRCP, provide structural detail of this anomaly but less sensitive for the function, that is the bile flow. D, upper GI contrast study that evaluates intestinal obstruction and not biliary pathology. Reference: Nelson Pediatrics, 21st edition. Coming to MCQ number 5, a 10-week-old infant is diagnosed with biliary atresia. What is the first line surgical treatment? A. Liver transplant. B. Cholecystectomy. C. Kasai's portoenterostomy. D. Endoscopic biliary dilation. Dilation. Correct answer is of course C. Kasai's portoenterostomy must be done immediately. Because Kasai's procedure connects the jejunum to the porta hepatis to restore the bile flow in infants. Porta hepatis means you have to score that or inside that porta hepatis so that the microtubules, the hepatic micro ducts will open, and then you have to connect that jejunum into that one. Jejunum should be connected to the porta hepatis. That is the hepatico-jejunostomy, it's called. And it should be the bile flow in infants to restore before 3 months. Ideally should be done within 2 months, but beyond 3 months, probably all microtubules will get fibrous. A is incorrect, that is liver transplant is used if Kasai's operation fails, even after 2-3 times. Because Kasai once failed, usually we do what is called redo Kasai. Even that is a failure, then by this time, baby might have gone for cirrhosis liver with biliary cirrhosis. Then liver transplant is the only chance for the baby to survive. Cholecystectomy, gallbladder is usually absent. Yeah, absent because not developed at all. And C is the correct answer. D is endoscopic biliary dilation because it is atretic. We cannot do dilation of the biliary ducts. So it is not effective. Cannot be done at all. Reference is Sebastian 21st edition pediatric surgery chapter. Coming to MCQ number 6. A 12-week-old baby underwent a successful Kasai procedure. 1 month later, she develops fever, vomiting, and worsening jaundice after surgery. So what is the most likely cause? A. Viral hepatitis. B. Bacterial cholangitis. C. Recurrent atresia. D. Kasai anastomotic leak. So among this, the correct answer is of course B. Bacterial cholangitis. Cholangitis is the most common complication after Kasai due to bacterial ascent through the Roux-en-Y limb. Through that jejunal limb, infection may ascend. It is ascending bacterial cholangitis. A. Viral hepatitis is wrong because it is less common acutely. C is recurrent atresia. Usually it won't recur, but the portoenterostomy can fail. D. Kasai anastomotic leak. It present earlier, not 1 month later. So that is also incorrect. Reference Swartz Principles of Surgery, 11th edition, Pediatric Surgery chapter. Coming to MCQ number 7. An infant present with biliary atresia and associated situs inversus polysplenia and preduodenal portal vein. What is the likely variant of this atresia? A. Isolated biliary atresia. B. Type 1 choledochal cyst. C. Biliary atresia with splenic malformation syndrome. D. Alagli syndrome. The correct answer is of course C. Biliary atresia with splenic malformation syndrome. Explanation: a syndromic variant of biliary atresia with multiple congenital anomaly, especially polysplenia. A. Isolated biliary atresia would not include other anomalies. There won't be any associated anomalies at all. B is also incorrect. That is, type 1 choledoccal cyst causes cystic dilatation, not arthritic actually. And Alagdi syndrome has butterfly-shaped vertebra, heart defect, and not situs inversus anomaly. So reference Journal of Pediatric Surgery, this particular edition. Coming to MCQ 8. What is the typical age at which biliary atresia first present with jaundice? A. At birth. B. Within 2 to 4 weeks of life. C. After 2 to 4 weeks. D. After months of birth. E. In adolescence. So the correct answer is B. Within 2 to 4 weeks of life. Explanation. Jaundice persisting beyond 2 weeks, especially with pale stool, suggests biliary atresia. At birth, immediate jaundice is usually physiological or hemolytic and not because of biliary atresia. C and D, that is after 2 to 4 weeks or after months after birth, is not correct, incorrect. Because it is between 2 to 4 weeks, jaundice is biliary atresia. C and D is after, because biliary atresia is a neonatal condition. Ideally, neonatal means up to 24 days, but not at birth. From 2 weeks onwards, after 2 weeks, but before 4 weeks, or even sometimes after 4 weeks also. Reference is Nelson's Pediatrics, chapter 410. Coming to MCQ number 9, which histological feature is characteristic of biliary atresia? Number A, central vein necrosis. B, biliary duct paucity. C, portal tract fibrosis with bile plugs. D, giant cell hepatitis. Correct answer is of course C, portal tract fibrosis with bile plugs. Because the biopsy in biliary atresia shows expanded portal tracts, bile duct proliferation, fibrosis with bile plugs. This is the correct answer. A, central vein necrosis seen in ischemic hepatitis. B, bile duct paucity seen in Alagdi syndrome. D, giant cell hepatitis seen in neonatal hepatitis. Reference Robbins' pathological basis of disease, 10th edition. Coming to MCQ number 10. What is the most important long-term complication of biliary atresia even after Kasai procedure? A, hepatic adenoma. B, cirrhosis and portal hypertension. D, recurrent stones. D, metabolic acidosis. Of course, the correct answer is B, cirrhosis and portal hypertension. Progressive fibrosis, despite Kasai's operation, leads to cirrhosis, that is biliary cirrhosis, requiring transplant in many patients. Hepatic adenoma is rare in infants, and recurrent stones, not typical in atresia. Metabolic acidosis is not a sequelae of biliary obstruction. So reference Bailey and Love 28th edition pediatric surgery chapter. These are the various reference books. The first two are problem-oriented book, the Hand and Muscles, 3rd edition, and Clinical Surgery by Mohan D. Silva, 2nd edition. Both are problem-oriented books. I think in the literature only these two books and one more, Learning Surgery, is the 3rd book. I know only 3 books, exclusively problem-oriented approach, not system-oriented or disease-oriented. Okay? Problem-based teaching is only these 3 books. And all other books, See 100 cases, case files, yeah, all the surgery review by Pestana, clinical surgery, Pulse, NMS, all are case-based teaching. So you can go through these books, maybe probably in your library, and you please work out all these case scenario given in these books. Because nowadays, majority of your MCQs are going to be case-based question. No longer they are going to ask you recall question. If at all they are going to ask, it will be only 10 to 20%. Majority will be case-based or clinical oriented. So please go through these books. Not only Bailey and Love or Subiston is not enough. So you have to work out all these case-based books also. If you want to learn about what are the books for general surgery to become a very competent, skillful general surgeon, please click this link and watch my video on general surgery books for making of a surgeon. So please go through this video as well. So this is my own book. I have written this book especially for my own students, and I said I am not producing it commercially because I have prepared, and even for you, okay, I am giving free. So you can go and just click this link, download this book. This book contains more than 120 actual cases, clinical cases, 9 modules it contains. Please go through it and please work out all these, case scenarios. It will be very helpful for answering your MCQ exam. And this is a course actually. Yeah, sorry. This is not the course. Sorry, this is the same thing, same 120 case scenarios. I will be teaching in the YouTube as a playlist of videos. You go and watch 9 modules. There are 9 videos. So for each module, I have produced, and I am discussing what are the questions and answers also I am discussing. Please either go and download this book and read, or you can go and watch these videos. So thank you very much for watching this video. If you think that all these videos are very helpful to you, kindly share these videos in your social media. Kindly click the bell button also to get notified regarding my latest upload. Thank you once again for watching this video. Let us meet once again in the next episode. Until then, bye-bye.